To the House of Commons Standing Committee on Health. Today we meet with witnesses on our study of children's health. We'll then move to committee business at 12:30. One of the items we will consider is Bill S-203 and any other items that will come before the committee. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. For the witness that we have via video conference, you will notice on the bottom of your screen that you have the choice of floor, English, or French for interpretation. For those in the room, of course, you have your earpiece and you can choose the desired channel. Screenshots or taking photos of your screen are not permitted. The proceedings today will be made available via the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. We'd now like to welcome the witnesses who are with us this afternoon. Dr. Anne-Monique Nuy, Directrice et Chef Département de Pédiatrie.
Director and Head of the Pediatrics Department, University of Montreal, and the Saint-Justine University Hospital Centre.
Carolyn Quash, pédiatre et
Doctor of Pediatrics, microbiologist, infectologist, University of Montreal, and from Saint-Justine Hospital.
Caring Society of Canada. Thank you all for taking the time to appear today. Each witness has up to 5 minutes for an opening statement. Nous allons commencer avec...
We are going to begin with Dr. Nuy, and I wish you a warm welcome, and I give you the floor. Thank you very much, Chair. Good morning to you all. I will be speaking in French, and I can answer questions in French or English. Thank you for the invitation to appear before you and speak to you about issues of particular importance to us in our country. My name is Anne-Monique Nuy, and I'm a pediatrician specializing in neonatal intensive care and clinical researcher. And as the Chair just said, I'm here before you as the head of Department of Pediatrics at the CHU Saint-Justine Hospital and Director of Department of Pediatrics at the Faculty of Medicine at the Université de Mons. I'm also President of Pediatrics Chair of Canada. We're 17 medical schools and therefore 17 academic pediatric departments in Canada. Our mission is to train all pediatricians in the country and for a number of these departments to train pediatric subspecialists. Our mission is to create new knowledge through research to establish best practices in pediatric medicine and to share the best possible quality of care in our tertiary and quaternary hospitals. And I'd like to talk specifically about 3 issues that are critical to children. First, the issue of the number of pediatric subspecialists. I know that a number of colleagues have appeared before you, before me, and have told you about the major problem of access to community care by nurse specialists, family doctors, and general pediatricians. And even if this were resolved, many children will continue to need specialists and subspecialist care. Unlike adult medicine, the majority of these subspecialized care is provided in pediatric teaching hospitals, as these are often small teams of doctors whose expertise must be concentrated to ensure and maintain a high standard of care. As department heads, we therefore have to find, recruit, and retain these specialists. The majority of our pediatric hospitals face major challenges in fulfilling this mandate. It's important to understand that seats in pediatric subspecialty training programs are under provincial jurisdiction. It is a few programs in a few provinces that train subspecialists for the entire country. Without a national concerted and collaborative workforce plan, we cannot hope to train enough specialists for the needs of all children in the country. So, therefore, we have to turn to abroad. And at this point, at this time, 25% of specialists in my department were recruited from abroad. And of course, this is very enriching. It provides exchanges of knowledge and experience that benefit everyone. However, the recognition of diplomas can differ from one province to another, even with regard to countries, for instance, Belgium, Spain, the United States. And overall, the immigration procedure is cumbersome and lengthy. So a concerted interprovincial approach under national leadership would be important to update. Second, I would like to share with you that the entire Canadian pediatric academic community recognizes the importance of having access to quality data to fulfill our missions. We need data to support research in pediatric diseases. We need data to identify priorities in pediatric care, example, immunization rights, obesity, neurodevelopment difficulties, and adolescent mental health. We need data to establish and validate best practices in pediatrics and monitor quality of our specialty and subspecialty care. And each center needs to benchmark itself against others. And because we're a small number of pediatric hospitals and the number of children each specialty treats is small, it's very difficult to make comparisons on a provincial scale. Even for the most populous provinces, no center wants to compare itself to its provincial neighbor. So the third thing is access to medication for children. As the Goodman Center's work under scientific direction of Dr. Kathleen L'Italian demonstrated, Canada lags significantly behind jurisdictions such as the FDA and European Medicines Agency in its regulatory arsenal for access to medicines for Canadian children. The Goodman Pediatric Formulation Centre and the Institute for Safe Medication Practices in Canada has tabled a paper on this issue for your committee. There are two levels of problem. First, access to drugs, new and old, that could be used to treat children. For these drugs to be accessible to children, companies must apply to Health Canada. Understandably, the administrative burden of this process, coupled with a small market for children, is not attractive for these companies. So, to address the reality, agencies such as FDA or the EMEA in Europe have put in place regulations that require applications for pediatric use and or studies in children when a new drug is filed that may also have a pediatric use. And here, we'd like to underscore that Health Canada prioritizes a pediatric action plan, and we're grateful for this, and we very much hope that the experiences of our international colleagues will be put to good use for Canadian children. Secondly, with regard to medicine, the problem of access to pediatric formulations of drugs, for example, syrups. So these would be medicines already approved for children. We understand the importance of not only the drug being approved by Health Canada, but also the pediatric formulation. This needs to be validated, for example, the concentration of the drug in a syrup and of its stability. And here again, Canada is clearly behind in its approval of pediatric formulations. To give you an example of the magnitude of the problem, for almost half of the drugs for which the pharmacy of Saint-Justine has to make an in-house formulation, crush the pill and turn it into syrup, such a formulation already exists commercially under the FDA or the European agency. So there be strong incentives are needed for companies to file applications. And but this will not be enough, as many drugs are even off patent, and the pediatric community is calling for the trusted foreign jurisdiction pathway for this to be explored by Health Canada. So the drug needs of children are different from those of adults and deserve specific regulatory attention, which should be put in place quickly. Thank you for your invitation, for listening, and especially for the way you will carry on with these hearings. We believe it's essential that there be open and frank communication between policymakers and at all levels, decision makers, and pediatric primary and specialty care community. Children's health and care particular needs your attention. Clinicians and researchers are dedicated. We want to share with you our reality and give you good evidence so that our government's decisions are well informed. Thank you.
Oui, et suite.
Next, we have Dr. Quash.
Parole.
The floor is yours, and welcome to our committee. Thank you very much, Chair, and all members of the Standing Committee on Health. Thank you for this invitation to testify on this panel on children's health. I'm a pediatrician, microbiologist, infectologist, and clinical researcher at CHU Saint-Justine, and a full professor at the Department of Microbiology at University of Montreal. I also hold a research chair in infection control, and I am also director of the Pediatric Outcome Improvement through Coordination of Research Networks, POPCORN, this for a period of 2 years, whose goals are to enable the research follow-up of a child through his or her trajectory of care in the country's 16 pediatric hospitals and to strengthen national infrastructure, expertise, and human capital, and to study the impacts of interventions or events on mental health and the development of children in Canada. So the CIHR has requested that the network study the impacts of COVID-19 in children and organize a national conference in May 2023 to share preliminary results and plan next steps. My clinical and research expertise in the areas of infection control and vaccination. So I'm going to focus on these two issues at the risk of my children telling me to stay in your lane. Although we all take vaccination for granted and feel that vaccine-preventable diseases are a thing of the past, it's important to realize that our world is still full of diseases that we thought were extinct. Take polio, for example. Until last year, no one would have thought that a case would occur in New York State. So wastewater surveillance has shown here and elsewhere that the virus was being excreted and that without vaccination, an individual was at risk of infection. Most of us are too young to remember the devastation caused by polio, the deaths, paralysis in previously healthy children. Similarly, measles still wreaks havoc, even in developed countries. When immunization coverage falls below 95%. Almost 20,000 people have just been exposed to a case of measles in Kentucky. The risk of importing a case exists, and young children are at the greatest risk of severe disease. So, is immunization coverage so low? Why? In 2019, the Institut National de Santé Publique du Québec did a survey on vaccination coverage, which revealed that by the age of 15 months, nearly 95% of children had received all their doses of polio, measles, and pneumococcal vaccines. However, in immunization records, measles coverage is more likely to be around 85%, with the actual estimate probably somewhere in between. Now, the impact of the pandemic on vaccination coverage has yet to be assessed. We're under the impression that issues surrounding the efficacy and safety of COVID-19 vaccines probably blunted the confidence of some parents in vaccines that have been in use for decades. So the trust needs to be rebuilt, or we risk return of these vaccine-preventable diseases with their attendant complications, meningitis, encephalitis, deafness, long-term sequelae, and death. Moreover, infectious diseases are democratic and affect everyone, but have a greater impact on vulnerable groups, both medically and socio-demographically. Health inequities are also seen in infectious diseases. A child in daycare is expected to catch on average 8 to 12 colds a year. These infections are not entirely preventable. And with the pandemic, we have seen a recrudescence of this. So we have an increase in bacterial superinfections, orbital cellulitis, mastoiditis, pulmonary abscesses, etc. To date, antibiotic resistances to these bacteria remain stable in Canada, but inappropriate use of these these antibiotics, difficulty in diagnosing and differentiating between viral and bacterial infections, and globalization could jeopardize these taken for granted treatments. Antibiotic resistance is potentially the next pandemic we face. In addition, more and more studies are beginning to link exposure to various environmental contaminants to a decrease in immune response. This research should be pursued with the One Health concept in mind, which promotes an integrated, systemic, and unified approach to human, animal, and environmental health. We're currently trying to understand whether the recent increase in incidence of viral infections is only due to a cohort effect, and whether the severe bacterial infections are only the consequences of the increased number of viral infections, or rather the consequences of the emergence of more virulent bacterial clones. It's therefore essential to have surveillance programs, including genomic surveillance of infectious diseases across Canada. One of the cornerstones of infection control is to ensure that measures are put in place and they don't result in significant collateral damage. These nuances are often difficult to communicate to the public. Popcorn will be able to answer these questions. However, it would have been more useful in children's health if children's health had been considered earlier in the pandemic and not just in 2022. In conclusion, the importance of infection prevention and the research that should support it cannot be overemphasized. In order to maintain gains in child health, adequate investment in this key area of health will save lives and public funds. Thus, we need to understand and measure the impact of the pandemic on immunization coverage and restore parental confidence where appropriate. And we have to ensure effective surveillance programs, including genomics, because this is the way we can measure the burden of infectious and vaccine-preventable diseases, with results that are accessible to all. 3, ensure that children's health is considered in research as a research priority and that their networks are funded, and not just for short periods, and provide the resources and actions necessary to prevent the emergence of antibiotic resistance, and ensure that the concept of One Health is put forward in child health decisions and research. I want to thank you for your attention, and I'll be happy to answer questions. Thank you, Dr. Quash.
I'm honored to call on Dr. Cindy Blackstock, Executive Director of First Nations Child and Family Caring Society of Canada, to address the committee. Welcome, Dr. Blackstock. You have the floor.
Thank you, and a very good morning, Chair and members. And I'd like to recognize that this testimony is occurring on the unceded and unsurrendered territory of the Algonquin Nation. In 2008, the World Health Organization said inequality is killing on a grand scale. Now, there's all kinds of inequality flowing from capitalist markets and other things, but there's also inequality that is directly sourced in the decisions that are made in this House. Made in this House and made in the Senate. And that's a story I want to talk about today, about how that inequality has killed First Nations children and how it's contributing to the deaths of First Nations children today, and most importantly, what you all can do about it. In 1907, headlines across the country were reading things like absolute bare attention to the bare necessities of health, startling death rolls revealed. What were they talking about? Canada's own medical inspector for the Indian Department had found that the federal government was underfunding health care for First Nations children in those schools. By how much, you might ask? Well, the people living here in Ottawa received 3 times the amount of health care funding that all, quote, Indians across the country. That gross inequality, coupled with poor health practices, was resulting in death rates of 25% per year, growing to 50% over 3 years. The Government of Canada accepted those statistics. They did nothing about the inequality. And where does that inequality come from? It comes from the Indian Act, where the federal government funds public services on reserve, everything from water to health to education to childcare, and the provinces fund it for everyone else. And since Confederation has underfunded those services, creating a cascade of poor health outcomes for First Nations children. Now, though it's that decision, it was a decision. It wasn't a failure by Canada. It was a decision to not remedy those inequalities created ripples that we're seeing now, sadly, in the headlines of 2021 and 2022 with the children in unmarked graves. In 2005, Jordan River Anderson was in a hospital in Winnipeg. At the age of 2, he would have gone home. His pediatrician said it was time. But he didn't go home because he was a First Nations child. And there was a dispute between the government of Canada and the government of Manitoba about who should pay for his at-home care. Make no mistake, if he was non-Indigenous, he would have gone home. He dies in a hospital, never spending a day in a family home because of who he was. In 2007, the House of Commons, all members, and I want to thank all members of all parties, stood in unanimous support for Jordan's Principle, which is about First Nations kids getting the help they need when they need it. It's something every Canadian can get behind. But it has taken now 16 years of litigation, 25 non-compliance orders to get the government of Canada to a place where it's beginning to properly implement Jordan's Principle. And in the wake of that, in the non-compliance period, the deaths of 2 children have been linked to Canada's non-compliance, as it refused to provide medical care for mental health to 2 children who later die of suicide at the age of 12. We don't know if those deaths could have been prevented, but we know that there would have been a chance to prevent those deaths of those sacred children had those children received the types of supports that they can get. So Jordan's Principle is a very basic principle of Canadian health. We talk about universal health care, but actually when we get down to it, we really don't have that in Canada. And we've done some work to decide, well, what can be fixed around Jordan's Principle? Well, what we're finding is now, thankfully, due to the tribunal and collective work of First Nations leadership, that we're now giving out about 2 million services resulting from Jordan's Principle, which is a good thing, in health, education, those types of social supports. But we're also finding that it's funding gaps in these other underfunded services. You see, throughout Confederation, there hasn't been a comprehensive plan to cost out all those inequalities and remedy them all. And we know governments are capable of doing this. In fact, we did this in the Second World War and in the Marshall Plan along with allies. We rebuilt Europe by creating a multidisciplinary plan. Surely this is something we can do here. And the Spirit Bear Plan is the way to do that. We want to put the hands of that calculation out in the public parlance, getting someone like the Parliamentary Budget Officer to cost out all these inequalities and put to bed for all time this what amounts to be an apartheid public service system for First Nations kids, which contributes to their poor health outcomes. We also would like to see, for Jordan's Principle, the requests that comes in, of a large majority of them are actually for low dollar value items, huge dollar value items to that family, but low dollar value items for the government. And yet a request for, say, $150 to buy baby formula is put through the same red tape as a request for $5 million. That's not a good use of public servants' efforts. And we'd like to see that calibrated so that, you know, like any business that you might run, you have a certain dollar threshold below which it's nominally approved as long as there's a professional note saying the child needs that service. So it's not without any check systems. These types of things would create vast efficiencies. The other thing we're looking for is the litigation is still ongoing, but we still don't have an answer of what is going to happen for Jordan's Principle beyond year 5. The agreement in principle is a positive thing, but we need to know that this discrimination is never going to happen again in any country for any child in this nation. I mean, when we all saw the children in unmarked graves, when we all wore the orange T-shirts, we were making a promise to the residential school survivors to make sure that what happened to them doesn't happen to their grandchildren. And we have solutions on the books to be able to remedy this. This is not a problem without a solution. This is a solution without, so far, the political will to solve it. But with all of you, I'm sure we can get that done. Thank you.
Thank you, Dr. Blackstock. We're going to now move to rounds of questions, beginning with the Conservatives. Dr. Ellis, please, for 6 minutes.
The witnesses for being here today. A very important topic of children's health, and certainly a nice range of opinions here today, and I think that's very important that we understand that. First of all, Dr. Nuet, if I could start with you. You are someone with some expertise in this, and you spoke specifically in your opening statement about it. And through you, Chair, you talked about pediatricians, finding them, recruiting them, and retaining them, which of course is a very, very difficult topic that we're all very well aware of, not just in Canada, but perhaps around the world as well. But maybe you could share with the committee some of your thoughts around how we can best do that.
As I briefly concluded that paragraph, I think that we need to have even though this is, I understand, a provincial jurisdiction, but if we can have a global plan across Canada for planning the needs. And when I talk about pediatrician retention, I specifically spoke about what happens in our tertiary care hospitals. So I'm not talking about the community pediatricians, I'm talking about the specialists and subspecialists. And I think first we have to plan appropriately for the whole country how many we need to train and not just province by province. For example, in pediatric nephrology, there are 17 university hospitals that need pediatric nephrologists, but there are 6 or 7 centers that train them in 3 provinces. So obviously, if only calculation is made within a province, then it won't be enough. So I think there needs to be that. And then I think it's very interesting to be able to recruit specialists from other countries. We might not have all the expertise for every single little thing that we need. But in a way, if this could be facilitated in terms of recognition of diplomas, especially from medical schools, or I don't know how to call them, in other countries that we know are of equivalent quality, I think that could be of great importance. I know certain provinces have made certain agreements with certain countries, and that would certainly be of help.
One of the other things for you, Chair, you did touch on retention of pediatricians. You know, as we as physicians, as we go through our careers, part of the difficulty is, you know, for people who work in a fee-for-service environment. Of course, there's no ability to have a pension plan other than what you save yourself. Do you have any ideas around that on how we may be able to better plan ahead of when physicians might retire or how to retain them longer?
So I won't talk specifically about salaries, but I will bring two questions to the retention importance. One is that many pediatricians and subspecialists in the university hospital have other tasks than caring for patients. They have to teach the next generation pediatricians and family doctors what about pediatrics, and they have to do the research because we're responsible to generate the new knowledge. So that part needs to be taken into account when we're thinking like how much we pay those who are in university hospitals. That's number one. And number two, the major complaint I hear about my colleagues about pursuing their career is the lack of multidisciplinary help, the lack of the other professionals they need to do their job. Nutritionists, nurses, respiration therapists. There's such a lack of all these professionals that are essential to do the care that every specialty needs to do, that it's burning them out because they are really, burning out is when you can't do the job you're supposed to do and you want to do it.
Thank you for that. And the other topic I'd like to touch on as well is you did mention the concept of data, and certainly it is something that we talk a lot about. We've talked a lot about in this committee. We hear a lot about data, and we know the importance of it. Part of the difficulty, though, is how do you collect that data? What systems do you use? How do you communicate it amongst provinces and territories and the federal government, and to make this meaningful, to understand exactly how many, for instance, pediatricians do we have? How many pediatric nephrologists do we have? They're perhaps easier to count because there's not many of them. But general pediatricians in communities, to understand exactly how many we have, how much work they're doing, when they might retire, et cetera, et cetera. So do you have any ideas around that?
So I'm not a professional health service planner. I'm just a regular doctor. But I can just see there's a problem, so thank you for bringing this up again. All these data are within provinces, and I think to bring this topic to the interprovincial discussions could probably it's just a matter of helping each other here.
Yeah, certainly through you, Chair, that's one of the issues that we've had, though, is province working in silos. And I think perhaps maybe we do need to look to the pediatric community that perhaps you're a little bit better at that than adult physicians are, that idea of camaraderie. So maybe we can get some better ideas on how to share things through the pediatricians. So I thank you for that. I'll come, if I have time at some point, I'll come back to medications, but medication shortages, especially in the pediatric world, whether it be acetaminophen and ibuprofen over-the-counter medications, as you well know, or any pediatric oral antibiotics at the current time, they're critically short, as you well know as well. But that's something I think that we will need to touch on here in this committee and understand why the shortages exist and how to overcome those. So appreciate that.
Okay, thank you, Dr. Ellis. Next, Dr. Hanley, please, for 6 minutes.
C'est moi aujourd'hui. Thanks for all three of you for appearing today. Dr. Noit, I won't have time to ask you questions, but I appreciate your recommendations. They do echo some of our witnesses earlier in the study, as well as in our important workforce crisis study. Ms. Blackstock, pleasure to meet you. I know you've been in the Yukon many times, and I appreciate you have never been one to mince words, and I appreciate your frankness in this room as well. In the Yukon, just last month, we celebrated the 50th anniversary of Together Today for Our Children Tomorrow, and that was the beginning of the modern treaty process, not just for Yukon, but for the country. And over the next few decades, we came to realize 11 out of the 14 First Nations as self-governing. And I think the agreements on self-governing and the progress that we've made so far in the Yukon in child health and well-being are not coincidental. I want to just pay attention a little bit more to Jordan's principle. And I know that an example of the many areas of progress since Jordan principle, admittedly driven by the courts, but now we do have it. I was just in Haines Junction on this past weekend at the Shothan Nazi Recovery Support Program, amazing family support program for recovering adults to support those families in recovery. And they said this would not have been possible without Jordan's principle. So as we contemplate your recommendations on Spirit Bear Plan, do you see the ongoing Jordan's principle and the extension as a transition, therefore, to something more comprehensive and enduring to continue to right the wrongs?
Yeah, thank you very much, member. And the type of story you're telling is something that echoes across the country in terms of the wonderful outcomes that can come from remedying these inequalities and getting services for kids. We know, from example, from World Nobel Prize winning economist James Heckman, that for every dollar a government spends on a child, it will save many-fold that number downstream. This is something that I know my colleagues will agree with. And so although we're spending money on Jordan's principle now, we can expect to get savings as the public purse downstream. But more importantly, this could be the first generation of First Nations kids that never have to recover from their childhoods. And that's the importance of Jordan's principle and the equality measures that it represents. So if we're able to, for example, continue on with Jordan's principle, which is a legal requirement now in a country and something that should be embraced, especially for those who are really fiscally prudent, it should be embraced and preserved as a measure. But we need to plug the holes in the other underfunded services, because that's really the answer, right, is to make sure that when a First Nations child goes into a school that it doesn't have black mold, that there are a number of teachers there that can support that young person. And as you're pointing out in terms of the tie to self-government, we need to make sure that the services are culturally appropriate and take into context the culture and language of that particular student.
Thank you very much. I'm going to turn to Dr. Quash. First of all, congratulations to the translator for being able to keep up with you as you read through an encyclopedia of recommendations. And I just wanted to maybe focus on a couple of areas. One, you did mention the importance of recognizing antibiotic resistance, and I wondered if you could. This is such a huge area, and I think we have slowed down over the pandemic, as in many other areas, our attention. Could you review very quickly maybe a few key policy steps that we need to be looking at for addressing antibiotic resistance, particularly using the One Health concept that you referred to?
Yeah, absolutely. Thank you. And thank you to the translator for being so good. I know I speak quickly. So just to set the stage, antibiotic resistance occurs when a bacteria that used to be, that we were able to treat with a regular antibiotic is not treatable anymore. And so in some countries, we're seeing more and more death associated with it because a urinary tract infection, which is something quite common, could be non-treatable and lead to death, which should not be seen nowadays. So the policy steps that have been taken and that we still need to keep on taking, first of all, is to have data in terms of what antibiotics are used, what antibiotic resistance we're seeing in various infections. And again, as Dr. Nuy was saying, it's not that easy to have access to data across the country. So there are a few programs that exist at the federal level. CNISP is one of those programs where, looking at nosocomial infection or healthcare-associated infections, we're able to follow antibiotic use and antimicrobial resistance. However, this program is limited to only 65 hospitals out of the 600 and something that exist in Canada. And so again, as Anne-Monique said, I think that particularly in pediatrics, if we want to have data that we're able to compare to, we need something that is national and not just provincial. So that's the first step. The second step, when we're talking about One Health, it means that whatever you use or you see in animals will eventually end up in human, whether it is through food, through close exposure. And so when we see antibiotic-resistant organisms arise in, let's say, chicken farms, it's very possible that people who are close to those chicken acquire them, and that eventually from transmission between humans, we're not able to treat those anymore. So surveillance in both the veterinary world, but also the human world is necessary. And we really need to have the possibility to do genomics to understand if a strain is related to another or not. At this point in time, these programs exist, but they are in specialized laboratory, in the public health laboratories. And so we need to have a better access to those and make sure that those programs are well funded across the country and at the federal level, so in the provinces and at the national microbiology. And the last thing is to promote innovation in terms of new antibiotics. So you're not going to see a lot of new antibiotics come up. Manufacturers and pharmaceutical industries are not tempted to put new antibiotics out on the market. It costs them a lot of money. It's labor intensive. Yeah. And again, when a new antibiotic comes out, the last population that has access to it is again pediatrics. So coming around to what Dr. Nuy was saying in terms of availability of drugs.
Thank you, Dr. Quash. Suite, Monsieur Thériault.
Next, Mr. Thériault, 6 minutes. Thank you, Chair. I think we're really privileged this morning to have such competent witnesses. It'd be so interesting to spend many hours with you, and I only have 6 minutes. First, Dr. Nuy. My colleague, Dr. Ellis, asked you questions which I would have asked you. So if I have time later, I will come back to some of your research on premature birth and impacts that it can have on children's health. Dr. Quash, there is a sentence that you spoke that really struck me. Antibiotic resistance is potentially the next pandemic we'll face. Now, that statement, it really gives me the shivers. And I would like to ask you if you could elaborate on that idea. I expect there's a clinical reality, socio-democratic reality. Could you expand on that, please? What should we do to prevent that? Well, thank you very much, Mr. Tellier, for the question. I addressed the question in part in my previous answer. So the World Health Organization has put on a list the 10 biggest threats to health, the antimicrobitic resistance. And, if children are exposed, they can develop resistance. And those genes can be passed on to, some pathogens that might not be treatable. Let's take, for example, our children, those who have urinary tract infections. Repeatedly, because their urinary tract system is complex with reflux from the bladder up to the kidney. Those children tend to be treated in a recurrent way for urinary tract infection, and in their first year of life will deal with bacteria that cannot be treated with oral antibiotics. So a urinary tract infection that should be trivial will end up requiring hospitalization with broad-spectrum antibiotics for 10, 14 days intravenously, which can subsequently continue to promote resistance to so we need to know when to use and when not to use antibiotics because there are viral infections. We have to be able to make a diagnosis. This needs to be done with general practitioners. We have to be able to distinguish between bacterial and viral. And of course, doctors might believe it's a bacterial infection when in fact it's only a viral infection. And children can have fevers 10, 12 times a day because they're going to catch 10, 12 viruses in their first year. But do we have the technological means that we need in these GPs' offices to be able to make that distinction? No. To date, we do not. So we have to promote research, innovation, so that we can have the point-of-care tests to be able to facilitate that work. During the pandemic, we saw that rapid tests to detect SARS-CoV existed. There are for Streptococcus group A, for laryngitis, and for respiratory infections. They are not perfect, but they certainly help. These are not necessarily easily accessible, but they're tests that are very expensive based on PCR technologies. But the whole idea is to find ways to do things so that those technologies can end up in frontline offices. It might well be expensive, but if the resistance to antibiotics becomes a next pandemic, it's going to cost us a lot more than it would have taken to adopt the measures on a timely basis. Absolutely. In your presentation, you talk about the cornerstone to prevention of infection is to ensure that measures put in place do not give rise to significant collateral damage. The nuances are difficult to convey to the public, and research and evaluation is crucial. And you then refer to popcorn. Could you please tell us more about popcorn so that we are far more able when the time comes to convey messages on public health? I mean, if the messages don't get through to the public, we don't have public health. Yes, in that context, we need the data to explain and understand the impacts of our recommendations. I'll take the example of Quebec. March 13, 2020, we decided to close all the schools. Most of us wondered, was it really the right thing to do? You'll recall that back then we had no choice. We had no data. There was no probing evidence. We didn't know how serious this was going to be. We closed the schools, but not understanding the impacts of the school closures. How long can we keep them closed? So Popcorn is a network, includes the 16 pediatric hospitals. We're missing Thunder Bay, but 16 pediatric hospitals in Canada examining, the administrative data to measure the impact on children subsequent to the COVID pandemic. We want to be able to come up with the evidence so that decision makers can come up with the right policies. So there will be a next pandemic. And if we have to be able to do, a cost-benefit analysis to really know what to do, both to prevent transmission, because we don't want to flood the hospitals, but we have to understand what consequences you have to be able to, see the future. So when you think about the schools, I think, tutoring was huge when it comes to recovering lost school hours. But we need to be able to examine what's happened before making recommendations.
Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to all three witnesses for your extensive experience and wisdom. Dr. Blackstock, I'd like to direct my questions to you to begin. Broadly speaking, how do Indigenous children rate in major health categories compared to non-Indigenous children in Canada? Can you give us a couple of examples?
Unfortunately, First Nations, Métis, and Inuit kids are often at the top of every list you don't want to be at the top of, and the bottom of every list that you do want to be at the top of. We're seeing everything from higher rates of death due to accidental injury, due to mental health issues. It really is cross-cutting, and so those inequalities that really put these families and these children in a difficult spot. First of all, because you don't have clean drinking water, you don't have, you have overcrowded houses. For example, during the pandemic, a lot of the public health measures we were taking advantage of weren't available. Only 35% of First Nations homes have broadband access. So even like remote learning or telemedicine aren't an option in those kinds of circumstances. So it really is, unfortunately, a cross-cutting disadvantage. And I think that part of the solutions are mentioned by my colleagues. The other is addressing the fire that leads to all of those health disadvantages, which is largely the inequality.
Now, in your written submission to this committee, you noted that, and I'll quote you, Jordan's principle is working to advance formal equality but is not achieving substantive equality. I take it, so a two-part question. Has the federal government fully implemented Jordan's principle to date? And could you explain the difference between formal and substantive equality? Maybe outline why Jordan's principle is only achieving the former.
All right, I'll start with this second part. There's a great quote in 1955 from the U.S. Supreme Court on this question. It says that there is no greater inequality than the equal treatment of unequals. And really what it is, if a substantive equality is recognizing the disadvantage that's been foisted on First Nations, Métis, and Inuit children that is not experienced by other children. So you need to invest more to make up for that, right? That's what substantive equality is about, is giving them the opportunity to have the same outcome other people who have not experienced those hardships have. In terms of, I'm just thinking of the other part of your question, which I've lost track of.
Whether the federal government has actually fully implemented Jordan's principle.
Well, it's much better than it used to be, but it is not full compliance in our view. And that's what we need to work towards before the tribunal will end its jurisdiction in this case. And that's something we're hoping that will happen soon, that we'll be able to get these matters addressed and have a long-term approach for Jordan's principle that will meet the criteria that the tribunal legally requires, and that is to stop the discrimination happening to First Nations children. But most importantly, make sure it doesn't happen again.
On that point, the Canadian Human Rights Tribunal has issued 24 procedural and non-compliance orders against Canada following the landmark decision in 2016. Yeah. Is the federal government currently in compliance with all tribunal orders?
No, and that's why we still have to. We're still in front of the tribunal. Again, I would say that there is greater progress, But no, there is not full compliance.
Now, I want to shift a bit to access of Indigenous children to culturally competent care. Can you maybe give us your thoughts on whether Indigenous children are getting such access, and if so, what can the federal government do to address that?
Well, I think that this is one of the critical areas where there needs to be further work done. That would include, for example, ensuring that the good work done by Dr. Kent Saylor, who is a Mohawk pediatrician who developed training programs for pediatricians on working with First Nations, Métis, and Inuit children, that is not only just provided to pediatricians, but rolled out writ large to every healthcare provider that's in the country, so that people are better prepared to meet the distinct needs of these children. The other, of course, is to ensure that in the communities there are primary healthcare providers and others secondary care that is available, that's culturally appropriate, where children actually can get services in their language. I mean, this is something that's very important across the country and something that's possible to do here.
I'll focus on one particular ailment. I know Indigenous people in Canada continue to be disproportionately affected by tuberculosis, and that's a disparity rooted primarily in factors such as poverty. You've mentioned crowded, inadequate housing, food insecurity. Children are especially vulnerable. They're more likely to develop disease and experience life-threatening conditions such as TB meningitis. Can you give us a flavor of what a culturally competent and community-driven TB elimination strategy would look like?
Well, I think the Inuit Tepersat Kitnami have really done a great job of documenting what that kind of intervention would look like. I mean, this is the good thing about these things, is that there are solutions that are on the books that just need to be mobilized and implemented. And as you're pointing out, that TB rate, particularly for Inuit, is just skyrocketing, but also for some of the First Nations in the country. And it is actually was tuberculosis that Dr. Bryce raised the red flag about in 1907. That drove those children into the unmarked graves. With not all the children, but many of those children died because of tuberculosis. And that's why he was calling for that inequality to be addressed too. So that's the opportunity we have right now, is that we don't make those headlines happen. We actually keep those children well because we can.
Mr. Chair, how much time do I have? If any?
You have about 15 seconds. You want to make a closing comment?
I'll give you the 15 seconds.
I would just say that Jordan's principle is one of the top TRC calls to action. When we look at the survivors' work plan for the country, which are the TRC calls to action, the top 6 are all about addressing the inequalities for the children, their grandchildren. They wanted their grandchildren to not have to go through what they went through, and they wanted the country to be better for it too. So it's about the TRC as well.
Thank you, Mr. Davies. Dr. Blackstock. Next, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses. Merci à tous les témoins. So I'm going to continue a little bit along the veins of Mr. Davies to Ms. Blackstock. Some of the questions, Canada has had a longstanding policy around birth evacuations in many of our isolated communities, and causing, at very high cost, moving Indigenous people away from family centers into urban centers to be able to just have a baby, which to me is insane. And I'm just wondering if you could speak to that a little bit and how that impacts both the mom and the baby and their health.
I mean, this is a very important kind of topic. You imagine when you're having a baby, right? You want your family around you. I mean, that's the whole thing around having this baby. It's a beautiful celebration of this new addition to the community. And traditionally, the birth of a child was a very spiritual, but a very important community moment as well. So removing that child and that mom from all their social support systems so that she can give birth to a baby hundreds of miles away, often without that support network, it makes no sense to me. And I think this gets back to ensuring that there's proper funding for healthcare services so that people can do the basic things like have a baby in your home community. And not to kind of do the Band-Aid solution, which is the medical transportation. In fact, when we look at Jordan's Principle member, one of the top categories that Jordan's Principle is funding is medical transportation. And that, to me, is a bit of a symbol of how short we are in terms of medical care in different communities.
No, and I thank you for that. And I know even I live in an urban center in Fort McMurray. And if I was deemed to be high risk at any point in time, I would actually have to go 500 kilometers away to Edmonton, which is insane because we simply don't have a NICU. And every single pregnant woman in my riding that lives in Fort Chipewyan is either having to go to Fort McMurray or to Edmonton away from family structures just to be able to have a baby. And I'm just wondering if anyone on this panel has any idea or thoughts around midwifery services of potentially playing a support and having some of that culturally sensitive care to help bring babies into the world in their communities.
I'll just add that I think that they're really essential. And having more schools to promote midwifery services, making them available in different communities, I think is really, really, really important. As well as all of the elements of prenatal care, to make sure that that's available.
No, fantastic. I couldn't agree more. I'm very proud to have an amazing Indigenous midwife who has cared for me in my first pregnancy and is now caring for me in my second pregnancy. And I know that I have a better experience because of that. Dr. Nui, j'ai vu que tu...
Dr. Nui, I would like to ask you about your vision on babies' care and midwives. I would like to stick to my field of expertise. So I'm a specialist in neonatal care, intensive neonatal care. So I think that question is one for obstetricians. I know that pregnancy, by definition, is not an illness, but if you have lower perinatal death or mortality rates, it's because things have either worsened, but there's certainly room for improvement. There are countries that have a great deal of experience with the use of midwives and midwifery.
To you, Dr. Nui, because I only have very little time. So my question is, how important is adequate prenatal care to overall infant health? Very important. Fantastic. and so the fact that many First Nations families and children and communities can't get access to adequate prenatal care is concerning to you?
I would say yes.
Thank you.
Thank you, Ms. Goodrich. Dr. Pawlowski, please, for 5 minutes.
Dr. Nui, you talked about the delays in getting approval for pediatric medications that aren't approved, that are already approved by FDA, and I think you said EMA is the comparable organization in Europe. You also talked about accessing pediatric formulas. In COVID, we saw jurisdictions around the world all independently having to decide on approving different vaccines, different treatments for COVID, which would seem to me a rather inefficient process. I don't know about you, but working as a doctor, one of the wonderful things I found about medicine is it's universal. People all around the world suffer from basically the same problems. When you open up someone, they're exactly the same. And now I'm going to ask you a bit of a political question. Given the delays in getting approval and the delays in smaller countries like Canada, which fall behind bigger countries like the FDA, which has more people, more ability to probably rapidly assess what drugs should be approved, does it make sense that every country has its own regulatory process? Do you think there's that we ought to be considering more of a global approach in terms of an international regulatory system to test and approve new vaccines and drugs, so that when we have something like COVID again, or there's new outbreaks of antimicrobial resistance, that we're better able to respond rapidly globally to these problems?
I think it's very logical. As you said, medicine is universal, and we read the research from our colleagues from everywhere. I think it's very important that within each country we have an entity that can be le garant, like Health Canada, that whatever is sold and approved in Canada is good for Canadian children and all Canadians. But what we're calling for is enhanced conversations and collaborations, exactly, and how can, whether it has to be only one jurisdiction or many, but facilitated jurisdiction, I think is beyond my competency to answer, but certainly we need to help each other, and probably this is what happened also during the pandemic, but Dr. Kwash's expertise on what happened with the vaccine approbation between all the countries is, she's going to be better than me to answer that one.
Well, maybe before turning to Dr. Quoc Tan about the same question, WHO is currently in the process of developing a new international treaty on control of infectious disease. Do you think that that should be something that perhaps is included in that treaty? So I'll ask you first, Dr. Nguyen, and then I'll turn to Dr. Quoc Tan for the same questions.
So certainly I think approval of medication needs to be accelerated, and sharing expertise. And in fact, children from Canada are recruited for medications that end up being approved in the US, but not in Canada. So for the initial studies, but then it's not approved in Canada. So it speaks to itself that we need to have some collaboration. To what extent, I'll leave that to the political aspects.
Dr. Quoc Tan, the same question or response?
Yeah, so I agree that more collaboration is needed. I still have to say, though, that during the pandemic, Canada had approvals almost at the same time as the US. And the reason why sometimes we make different recommendations is also based on our population, on our epidemiology, and other factors. But in terms of Health Canada, I have to say that they were quite expedient during the pandemic. They worked rapidly. They changed their process. They allowed NACI to be able to look at the data at the same time they were. And so, yes, collaboration, absolutely. I know that EMA in Europe has a collaborations between all European countries. Still, once EMA makes a recommendation, each country still has to review it. As Dr. Nguyen said, I still think we need to make sure that what we approve for our country is what we want, and the legal implication and the jurisdiction might be different. So agree with collaboration, but again, I'm not a regulator, so might as well ask Health Canada.
Sean, how much time do I have left?
20 seconds. You want to make a final comment?
Okay, no.
Thank you, Dr. Pawlowski. Monsieur Thériault, 2 minutes et demie.
Will you give me another 2 minutes, or is this the last one? It's the last one. Oh, dear. I will try my best. Dr. Nguyen, you've conducted research on the consequences of premature birth, and this on lifetime health. To your knowledge, how many studies have monitored cohorts of premature babies, be it in Canada or elsewhere in the world? Does that kind of study exist? How many? In Canada, I know of 2. There was one conducted by Dr. Sir Siegel in Ontario, and one I am leading in Quebec with Dr. Liu. There have been studies in the Scandinavian countries. In fact, there are more and more studies. Now, your studies, how many years do they monitor patients? Well, we've young right to adulthood, 25, 30 years. When you study the epidemiological data using, for example, Quebec's Medicare card, we can follow them till their mid-40s. So you have from birth until mid-40s a cohort of how many individuals? 100,000 premature. From what year to what year? When did it start? In Quebec, the birth data are reliable as of 1976, because there's a transition phase when we moved to the metric system. We're not 100% sure whether baby's weight was registered in pounds or kilos. So is it 3-pound baby or a kilo baby? So as of 1976, data is reliable. So we've been monitoring until now. So as of 97, we have very reliable data in Quebec, diagnoses, hospital stays, but we don't have reliable data on doctors' visits. If someone visits their doctor for diabetes or, something else, we only have a diagnosis. So in neonatology, given advances in research, until how many weeks is the fetus viable without disastrous consequences? Well, the definition of would be another 3-hour discussion, but children can be reanimated in most Western countries, or the wealthy countries, between 22 and 24 weeks, as of 22 to 24 weeks. Next, Mr. Davies.
Thanks, Dr. Blackstock. I wasn't sure if you were referring to a historical figure, but is there an accurate number relatively about what Canada spends today per capita on Indigenous children's health versus non-Indigenous children's health?
I don't have that information.
So when you referred to, I think, 3 times more, that was a historical figure?
Yes, that was a historical figure.
Okay.
The Auditor General's done some reviews of healthcare delivery in northern communities, et cetera. But this is why we want the Spirit Bear Plan, is to cost out those inequalities and propose remedies for
You
them.
anticipated my next question. I know that the Spirit Bear Plan was adopted by the Assembly of First Nations Chiefs and Assembly in 2017.
That's correct.
Could you outline the federal government's response to the Spirit Bear Plan to date? Have they committed to timely and full implementation of that plan?
No, they have not, and they have not proposed an alternative that would remedy those inequalities.
I want to just turn a bit to food insecurity. We've been hearing a lot of this committee. When we think of health in our health system, we often think of the treatment of illness once people are ill. But the determinants of health, preventative measures like making sure children have access to good nutrition, I think is something on our minds. Can you tell us what you think we should know about food insecurity and the impact of that on Indigenous children in Canada?
Yeah, I'm alive to the testimony yesterday of the large grocers and the impact that had on Canadians. But I can tell you that I've been to many northern communities where getting a small jar of peanut butter is $16. And that is before the inflation element. So being able to make choices about feeding your family a healthy diet is almost impossible in northern communities. And yet things like cigarettes and booze are often subsidized. I think that we need better subsidies to make sure that people in northern Canada who are living in these other areas are not paying prices for groceries that we are not even with inflation, even glimpsing at here in southern Canada.
I think we talked about data. Do you agree that Canada should have a national data strategy related to child and youth health, and of course, including an important focus, including of that with Indigenous children? Or like, what is the state of data in this country on Indigenous children's health?
It's not good. And in terms of the Truth and Reconciliation Commission pointed to that recommendation as one of its top calls to action. For example, in child welfare, countries like the United States that have 50 different U.S. states have national child welfare data collection systems so that we know about the kids who are in care and what their needs are and how they're doing over time. Australia has it. Canada does not have it. The rationale? It says we have 13 different districts. But surely if the United States can overcome 50, we have the competency to overcome 13. And this type of data is going to be very, very important for making sure that we are able to track whether or not the different interventions we're making, be they at the policy or at a treatment level, actually are working for kids.
Thank you so much for your
Blackstock.
testimony.
Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and I'm so impressed with the panel that we have here today. It's just amazing that your answers are so succinct and so clear and much appreciative to the committee. And for us in doing a study on children's health, where do you begin? I mean, there's so many avenues to touch on that, and how do we do that? So hopefully I can get a couple of questions in here anyway. Dr. Quach, and thank you for your work with NACI and when you presented to the committee in the past. We really do appreciate that. And over the years since COVID started, there have been a lot of things. And today you sort of touched on one thing that's of interest to me. Is in reality, you sort of mentioned about polio being back in the U.S. for the first time. And, you know, I've been to Islamabad, Pakistan, to the polio center there, and the great work that they're doing, the great work that all Rotarians do in Canada in helping to fund some of that programming to deal with the vaccinations with polio. You know, we have measles we're seeing parents that are not having their children vaccinated with measles. You know, we're seeing tuberculosis back in Canada. And that's something that a lot of Canadians don't even understand. In my hometown of Estevan, we had tuberculosis in the southeast corner of Saskatchewan. Most people think, so just in the north, so we don't have to think about it. So it's there, and we need to be touching on these things. And the concern we have is that when COVID came, unfortunately, it was such a scramble at a time that we got so much misinformation, and there were so many poor decisions or decisions that were made in haste that were then retracted, et cetera, that made it for example, the Public Health Agency of Canada were coming up with certain points and then changing those points. And so my question to you, Dr. Quach, is what do you see that we can do? How do we rebuild that trust? What would be one of the first steps we need to do to rebuild that trust with Canadians? Because they need to see that trust so that they can start recognizing the great value of vaccinations.
I mean, that's the million-dollar question. If I had the answer, I'd give it to you. I think the first thing is for people to understand what decisions were made based on science and what decisions were made that were political. And I don't know how easy that is. I don't know how to rebuild except to start discussing and talking and being able to say that there are some things that we don't know, but other things on which, you know, we have good evidence for. I think that one thing that is not about trust, but is the storytelling. So as you said, you've seen polio cases, but most of us have not. Grandparents who used to go to pool in the summer and not come back in the fall to school are not there anymore. So how do we ensure that parents understand that we have the data to prove that vaccines are safe, but that on top of that is that they are a great help to our health, and in fact they save our health. I think that with the pandemic, we are seeing more and more meningitis and other bacterial cases. Some of them are vaccine preventable, some are not, but it's just, you know, understanding that we still face infectious diseases. You were saying measles is back, syphilis is back. We're seeing congenital syphilis cases that we weren't seeing before, and that's not a vaccine preventable disease, but it's just a matter of understanding that these diseases are back, and if we don't maintain a good vaccination coverage, they will be back and will have deadly consequences. But I don't know where to start to rebuild trust except to discuss and have the frontline doctors, nurses discuss with their patients and make sure that those who are in contact with parents are able to have all the knowledge they need to have that conversation. So ensure that in medical school, in nursing schools, that we do have those conversations and those classes to make sure that people feel well-tooled, or outillés, I'd say in French, to be able to answer those questions that parents will have. Because in the end, those people that we listen to most, we as in parents, are the people that take care of our children. So I trust my physician. My doctor said, "Did you read about this and that for your child?" And I said, "No, I trust you. If you tell me that my child needs whatever medication, I will trust you." So trust starts there with our healthcare workers.
Thank you, and I appreciate that, and I appreciate your comments on recognizing that there is a difference, that certain diseases are of value with vaccines and certain ones are not, and basically we're dealing with antibiotics, that we need to deal with certain things, and you touched on that a little bit earlier. Dr. Blackstock, and I appreciate your comments, and my colleagues sort of touched on a little bit of base that I'm concerned about in basically competent care. And you know, and I have a number of First Nations in my riding, and in particular, one great First Nation, which is Cowess's First Nation, and the chief has done tremendous work there, and they started up a home for young girls, and this home for young girls from 10 girls in a home from 14 to 17, and the big challenges that they have as they're trying to bring them back and to get them where they were taken away and now coming back to get that support. If you want to just touch on that, I appreciate that, but as well as if you want to throw in a comment on how do we get that trust back, I'd be happy to hear that as well.
Question. For members' information, First Nations children, according to 2019 data, are 17.2 times more likely to be in child welfare care, owing to poverty, poor housing, caregiver substance misuse related to multi-generational trauma from residential schools. So what the work of Cowess is doing is about trying to address those drivers, which brings us back to the Spirit Bear plan, because that'll be a good success, under a self-government model. And it's going to be very important for the success, the long-term success of these initiatives, that equity and self-government go together. Substantive equality and equity and self-government go together so that you can continue these culturally based programs. Because really what we're doing is we're trying to address the trauma that is piled up since Confederation on these children and families and bring them back safely at home. But you can imagine, remember, if you're in a community where there is a housing shortage, how do you bring these children in care back home? If you're in a community where there is no water, how do you bring these children back home? So that's the part of it. In terms of the trust thing, it's always interesting. I hear people say, well, First Nations don't trust us. And I always say, well, the beginning is acting in trustworthy ways. And I think that begins with carrying out your promises and acting with integrity as government. I think that goes a long way in being able to address this. And when solutions are put forward to government, to have them really engage and critique them and really implement them if they seem to be in the best interest of public policy, which they often are.
Thank you, Dr. Blackstock. Final question for the panel will come from Mr. Van Couverden, please, for 5 minutes.
Thank you very much, Mr. Chair, and thank you very much to all the witnesses. This has been an extraordinary meeting and really, really helpful. And I'm glad that that everybody was able to come, and it's nice to have people in person as well. My first question is for Dr. Monique Nui. If you'll indulge me, I'm curious about healthy living and sustainable eating habits for young people. And as you stated, there's been a rise in negative eating habits and eating disorders. So I think it's incumbent upon us to recognize that and make sure there's an increase in services available for people who are suffering from eating disorders. But I also want to get at the root cause of that and try to prevent those if they're preventable, and support people with any type of a strategy that would help people develop good eating habits, feel more confident, feel a sense of belonging, and reduce that stress and anxiety that leads to those sorts of negative behaviors. Can you tell us some strategies that we might be able to support or employ that would support that?
Yeah, so rapidly, there are two elements in what you brought. First is the healthy habits that in general will lead rather to obesity, because when unhealthy diet in general is led to fatty foods, etc. So, and this is very much linked to indeed socioeconomic inequalities, and it's bringing back to everything my neighbor, Dr. Blackstock, said exactly. It's about for the First Nation children, but all children in Canada that need to have access to decent living conditions so that they have access to decent food and therefore healthy food habits. Regarding the problem with the anorexia and the eating disorders that we've seen, especially during the pandemic rise, this is also bringing us back to first-line care. You know, the youth, they have to be well in their families and they have to be well in their school. It's not going to prevent everything, obviously. As I said also, there will always be children that will need specialized care. But if we make sure that in the families, the parents are not always away working 3 jobs rather than just one, and if at school there are the services that they need, then we will prevent them from coming to the healthcare and coming to the hospital. Because children, where are they? They're in school. So we need to take care of the schools. And so I'm here, pediatrician, telling you take care also of the schools.
I'm happy to hear that as we're working on a child food program, our school food program, a national one that'll support food security at schools. I have a question about food insecurity and its link to, and we know that food insecurity is not about not enough food, it's a poverty issue. I want to make sure that I'm clear on that. But is there a relationship between socioeconomic status and disordered eating? And that relationship between disordered eating and food insecurity must be very complicated as well.
I do not know the answer to that question. I think these are really two different topics.
Okay, yeah, thanks. Dr. Blackstock, over to you. Next week I'm on my way to an event hosted by Spirit North, which is an organization that does physical activity programs for Indigenous kids. It's in Canmore. A lot of kids are coming from other regions and the First Nations communities in and around Canmore. Have you had a look, and what are your views on making sure that particularly Indigenous kids, but kids that live in remote communities, other disadvantaged communities, have access to those really positive social experiences that lead to better outcomes?
Oh, it's huge. I mean, we forget about childhood and the importance of play, right? And sometimes we pay a lot of attention to all these things that are risks and everything else. But part of being a kid is actually just having the time to play. And play is important to children's development. So making sure that children have access to all kinds of positive activities in rural and remote communities writ large is really, really important. And even in Jordan's Principle, we're seeing communities actually develop programs like that involve culture as well, right? So you embed the culture in the sport, or you embed the culture in the activity, so that it's meeting a bunch of developmental needs for kids, and they get to have some fun.
That's really great. I love that. I'd like to end on a positive note. We spend a lot of time in this committee talking about health care, which, as we all know, it's a system by which we take care of sick people, ill people, and I also like to focus a little bit on health. So if I have any moments left.
Yeah, about 10 seconds. You want to
Anybody like
say
to
goodbye?
address the precursors to health social determinants to ensure that we're not just focusing on taking care of sick people?
Take care of the schools. Take care of the schools as well. Thank you.
Yeah, and I'd say equality across the board in services.
All right, thank you, everyone. Thank you so much to our witnesses. It strikes me actually a little bit unfortunate with such expertise in front of us that we only had an hour and a half with you. But it was absolutely quality if it wasn't quantity. And so thank you so much for being with us. I'm sure you can feel the appreciation in the room for your experience and expertise and the manner in which you answered the questions. It will undoubtedly be of great value to us, as I think we have one more panel, or is this it? One more panel before we issue drafting instructions. So we're almost there. So thank you all. You are excused. To the members of Parliament in the room, we have a half an hour of some other business that we need to cover. So we're going to suspend now, but for probably just 3 or 4 minutes. So thanks again so much to our panel. And we're suspended. Okay, I call the meeting back to order. Colleagues, we have a couple of things on our agenda, and there's there's a motion on notice by Mr. Davies, who has his hand up, so I recognize Mr. Davies.
Thank you, Mr. Chair. As I've given notice of, I would like to move the following motion: that pursuant to Standing Order 1082, the committee conduct a study to investigate reports that the Minister of Health personally intervened with the Independent and Arm's-Length Patented Medicine Prices Review Board to indefinitely suspend reforms that would have saved Canadians billions on drug costs, that the committee invite the following witnesses, in addition to any further witnesses the committee may consider relevant: Honourable Jean-Yves Duclos, Minister of Health; Matthew Herder, former member, PMPRB; Melanie Bourassa-Forcier, former acting chair, PMPRB; and Douglas Clark, former executive director, PMPRB, and that the committee report its findings and recommendations to the House, and that, pursuant to Standing Order 109, the committee request that the government table a comprehensive response to the report. So I would move that motion, Mr. Chair.
Thank you, Mr. Davies. The next item on the agenda was 203, but I'm advised by the clerk that your motion is in order. So the debate is on the motion, and I recognize Mr. Van Couverden.
Thank you, Mr. Chair. I have an amendment to Mr. Davies' motion, and I'll read it. That pursuant to Standing Order 1082, the committee conduct a study on the Patented Medicine Prices Review Board, and that the committee invite the following witnesses, in addition to any further witnesses the committee may consider relevant: the Honourable Jean-Yves Duclos, Minister of Health; Matthew Herder, former member of the PMPRB; Melanie Bourassa-Forcier, former acting chair of the PMPRB; and Douglas Clark, former executive director, and that the committee report its findings and recommendations to the House, and that pursuant to Standing Order 109, the committee requests that the government table a comprehensive response to the report.
Okay, Mr. Van Couverden, that doesn't sound like an amendment that is actually identical to the original motion. So do you wish to amend the motion?
It's only slight.
What's different?
That we remove to investigate reports that the Minister of Health personally intervened, and that we remove to indefinitely suspend reform that would have saved billions of drug costs.
Okay. So the witness list remains the same, but the scope of the investigation has changed. So can you read the first up to the witness list again, please? Because that's the guts of the amendment.
Yeah, it's just been shortened to that pursuant and all of that. The committee conduct a study on the PMPRB board, and that the committee invite the following witnesses in addition to any others.
Okay.
can circulate it
Okay,
if you want.
the amendment is in order. If you have it to circulate, that would be helpful. Mr. Davies has his hand up.
I was just going to say, Mr. Vancouver and I have had a chance to discuss the amendment, and I would accept as a friendly amendment. It gets at the same substance, which is simply to focus on the PMPRB and obviously hear from the relevant witnesses on. It's broad enough to include the issues that were included in mine, and it removes language that perhaps were more directory. So I'm happy if there's a way to expedite this. I'm happy to say I accept that amendment and ask
Any
my colleagues.
further discussion on the amendment? Seeing none, is it the will of the committee to adopt? Oh, okay. Please reread the amendment. Wait.
Two, the committee conduct a study on the Patented Medicine Prices Review Board, that the committee invite the following witnesses in addition to any further witnesses the committee may consider relevant. The Honourable Jean-Yves Duclos, Minister of Health, Matthew Herter, former member of the PMPRB, Melanie Bourassa-Frossier, former acting chair of the PMPRB, Douglas Clark, former executive director, PMPRB, and that the committee report its findings and recommendations to the House, and that pursuant to Standing Order 109, the committee requests that the government table a comprehensive response to the report.
Any further discussion on the amendment? Are we ready for the question? All those in favor of the amendment, please raise your hand. The amendment is adopted. The debate is now on the main motion as amended. Mr. Davies?
Just in terms of scheduling, Mr. Chair, of course, this motion was stimulated by recent events. So what I would suggest is that, and I would leave it to you and the clerk to maybe work this out for next meeting, that we schedule one day, perhaps in early to mid-April, just to hear from these four witnesses. And then I think the committee can assess where we want to go from there. Because the motion does permit us to consider hearing from further witnesses if the committee believes we need to. It leaves it open. I'm mindful of people like former Chair Mitchell Levine is a potential other witness. And there may be even a couple people from civil society. I don't want to make that determination now because maybe these are all we need to hear from. But I do think that before we break for next week, I would like to ensure that we have one meeting to hear from these four witnesses sometime in April.
Any further discussion on the motion? Are we ready for the question? All those in favor of the motion as amended, please raise your hand. I see. All those opposed? Mr. Thériault.
Earlier, in the interpretation, I don't know if I heard correctly. In regard to the witnesses, we're going to hear from Mr. Duclos. So, Mr. Herter, Madame Forcier. Is that all? The list of witnesses has not changed in the amendment. Well, then I have an amendment to move. All right, then. Well, I would like to remove Mr. Clark. The reason is simple. We have three individuals who are linked to an event and who are in attendance at that event. And then we have someone who is not at all there. He was not at the PRMB at the time of the event. So if at a first meeting, 1 minute, Mr. Ter, Ms. Goodridge.
I believe we've already voted on the amendment to end the motion, so I'm not sure if this is in order to be discussing at this point.
Normally, I would be inclined to agree with you, but Mr. Terrio indicated that there was a problem with the translation that affected his ability to participate, and I think that in those circumstances, we may very well end up back in the same place, but I'd like to do it, extending to him the fairness that the situation calls for.
Point of order, Mr. Chair.
Yeah, Mr. Kitchen.
So, I mean, the fact that we voted, and it's been a recorded vote, we either have to rescind that vote in order to do that. You cannot, we've already had that vote. Even though there was an error, I get that, and I understand with the translation, but the vote was put in place. And from a procedural point of view, I would call for the clerk to maybe give us a better understanding of whether that can, but my understanding would be we voted on the motion, it has been approved, this would have to be a new motion, or we have to rescind the vote that we did.
I take your point of order. First of all, it wasn't a standing vote, but you've asked for a ruling on it. Mr. Terrio, did you have something that you want to add on the point of order?
Well, we held a vote on the amendment, Mr. Van Coretten's amendment. Now, before voting on the motion as amended, I indicated I wanted to move an amendment. And I believe that we can move an amendment after having voted on a preceding amendment. And I'm trying to explain my amendment. One moment, please. I need to give a ruling on the Mr. Kitchen wanted the clerk to intervene. I invite him to do so now.
So typically, yes, a vote that has taken place would need to be rescinded by unanimous consent in order to revoke the decision and then put another amendment forward. So if it was clear to the committee that the vote on the main motion had taken place, then that would be a typical way to proceed, for example, in the House. So unanimous consent could be granted to do that.
Okay, so I think that what I'm going to do is I'm going to reject the point of order and invite anyone and entertain Mr. Terrio's amendment, and it is open to anyone here to challenge the chair if they don't like that decision. Dr. Ellis.
And certainly, I will challenge the chair on that in the sense that we were actually, you were, sir, in the midst of counting the votes on the main motion at the time. And I think it was very clear around the table that there was a consensus. I'm fully respectful to the fact that Mr. Terrio missed the translation. I think that's very important. I think we all need to be respectful of that, but I think Dr. Kitchen's point is very important, that we also need to be respectful of the rules of how this committee should operate. Therefore, I would respectfully suggest that the chair consider another course of action and perhaps asking for unanimous consent to reverse direction. But simply because of the fact that I do believe that it's an exceedingly important point that Mr. Terrio is bringing forward. Again, I can't comment on the translation. I wasn't listening in French. So, however, I would suggest that because we're at the point of counting votes on the actual main motion, that the chair consider his ruling and move back to a different position. Thank you, sir.
Okay, a motion to challenge the chair is not debatable, so we're going to proceed directly to a vote, just so that we're all clear on what we're voting on. I have ruled that the motion has not been adopted, and that Mr. Terrio is to have the floor to move his amendment. And that ruling has been challenged, so the question for you is whether the ruling of the chair shall be sustained. Okay, and so do we need to do a standing vote on something like this?
No.
Okay. Okay, on a show of hands, shall the ruling of the chair that Mr. Theriault is now allowed to present an amendment, and the motion has not yet passed. Is it the will of the committee to sustain the ruling of the chair? Show of hands, please. All those in favor of sustaining the chair. 1, 2, 3, 4, 5. All those opposed? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Madame Sidou. Oui. Did you vote in favor or opposed? You're on mute.
Support the chair, Mr. Chair.
The ruling of the chair is sustained. The motion has not yet been adopted. Mr. Theriault, you have the floor.
Mr. Chair, there's a bit of an imbroglio at the PMPRB. This concerning the minister, and we have 2 letters of resignation. So I believe that's what we should stick to. At a first meeting, we hear from these people, and then in light of that, if ever we want to hear from other witness, that's not excluded because we have it already in the notice of motion. But Mr. Clark was not in the PMPRB at the time of these events. Now, if we deem that we want to shed further light on the matter, bringing in other witnesses at a second stage, we'll do so. But right now, I want to very quickly shed light on the 2 who resigned and the intervention of the minister. And that's why I think it'd be more appropriate to proceed this way. And it doesn't exclude the possibility of a second meeting if it's needed before we draw our conclusions. And that's why I moved my amendment. In fact, I'd already talked to Mr. Davies about that. My intention to do this was very clear. And I thought it was already in the amendment. I had not understood that it was not in the preceding amendment. For clarity purposes, you want to remove Mr. Clark? Yes, because he was not there. Although he was, an actor at PMPRB, but when you want to have someone intervene who was not there at the time of the events, it's like wanting to come back to the heart of the issue. But as far as I'm concerned, what we have before us is to assess why there were resignations and what the minister's intervention was in regard to those resignations. We had 2 resignations, 2 letters that are contradictory, moreover. And therefore, I think we need to work first with the main actors, and then, if need be, we'll hear from others. Mr. Davies?
The easiest way to deal with this is, with the greatest of respect to my colleague, is the one and only and paramount reason he's giving for not hearing from Mr. Clark is factually incorrect. Mr. Clark was there the whole time. He's still there, as a matter of fact. Mr. Clark has given notice of resignation. He was with the PMPRB throughout the entire process, is there today were you to phone over, and his resignation is effective in June. Now, I may have what he's doing today wrong, but he was throughout the entire exchange of documents and letters. Mr. Clark was the executive director of the PMPRB. Second of all, the reason that he's an essential witness is because as the executive director of the PMPRB, there's no one who is better placed to answer questions that may come from this committee about what was happening at the PMPRB than he. He's appeared before this committee before. He's encyclopedic in his knowledge. He's extraordinarily fair. He has no axe to grind, and he would be a resource. This committee, when we schedule witnesses, just about always schedules 4 witnesses. It's my motion that I put forward, and these are the 4 witnesses I want. This committee is always better served by hearing more evidence than not enough. If my colleague, Mr. Terrio, doesn't want to direct any questions towards Mr. Clark, he doesn't have to. He can focus his questions on whoever he chooses, of course, but Mr. Herder and Madame Forcier. But Mr. Clark is an indispensable source of knowledge about what's going on at the Patented Medicine Prices Review Board, and I think would be an indispensable witness for all witnesses here to question, because you do in fact, the last thing I'll say is you do have some contrary opinions about what happened. To have someone who was the executive director of the board and responsible for the day-to-day operations to be there to answer questions, to help us perhaps resolve from a person who's not intimately involved in the exchange of positions is, in my view, indispensable. So I would urge us to defeat this amendment and invite the 4 witnesses.
Dr. Ellis?
Thank you very much, Chair. You know, I think from a purely planning perspective, regardless of the quote-unquote he said, she said argument, I think it's important to this committee. We have a lot of work before us. I think that planning ahead and saying, let's have these specific witnesses, it may allow us to actually to not go into a second meeting with respect to this. So I think it's very important that we're very cognizant of the time restraints that we do have. And if we plan appropriately, then there's a good chance that we may actually be able to move more legislation through the committee, which I think is in essence an important consideration as well. So I thank you for that.
Mr. Thériault?
Oui, mais
Mr. Clark has already been heard from during the study we conducted on the reform of medicine pricing. He was amongst those who said that patient groups had been bought out by the pharmaceutical industry. I think he has, solid positions. When you read the 2 letters of resignation, you understand that in one case, one of the resignations, there's an allusion to certain internal resistance. So I don't know why we would invite someone who's resigned from their position, and be they still in the institution or not, is one thing, but that individual is nothing more than someone who has resigned. We know what that person's positions are, and if we want to hear from him, we can hear from him at a second stage. What I want to know is what justifies the resignation of Herder and Forcier, and what did the minister do in regard to those 2 resignations. I don't need light shed by a 4th person who hasn't produced any documentation for us to understand.
For some of us, this isn't our first time through the issue of the changes to the PMPRB. It is an exceedingly difficult topic for anyone to understand. I thought Mr. Clark...
il y a juste pas de traduction.
There was no interpretation.
Was a very good witness.
Does it work now? Okay, allez-y. Go ahead.
I think Mr. Clark last time around was very good at explaining some of the concepts to people who weren't familiar with this difficult and hard to understand area of regulation. So I think he would definitely be a good witness to have before us, given his familiarity with this exceedingly complex subject.
Mr. Davies?
Yeah, I just want to mention that a few things. Mr. Clark also resigned, so we have 3 resignations from the PMPRB. It's immaterial whether he disclosed a letter in public or not. There have been 3 high-profile resignations from the PMPRB. And the letters that have been sent out show that there's some issues that we need to look at. I think trying to find out why the executive director of the PMPRB resigned in these contexts is relevant. Number 2, we are not here to determine the merits of the substance of the PMPRB reforms. That's what Mr. Clark came to testify on before. That's not what we're looking into in this matter here. We're looking into the matters of the functioning of the board and potential issues of propriety. My final point is this. The reason that we almost have to have him is that he is referenced in Madame Bourassa Forcier's resignation letter twice. Sorry, I just lost the quotes. But she makes specific reference Mr. Douglas Clark. And so it would actually be fundamentally unfair to hear from Melanie Bourassa Forcier. And as she puts into evidence and comments on Mr. Clark, without Mr. Clark being here to hear that and respond, I'll read you excerpts from her letter. Following these two letters, I asked the executive director, who recently resigned from this position, if we had taken the time to meet with these stakeholders to understand their concerns in relation to the proposed guidelines, concerns that had not been brought to my attention as interim president. I therefore believed wrongly that our proposed guidelines posed no real problem. I then understood from the response of the executive director that he had met representatives of certain pharmaceutical companies and that he had never had any discussions with Health Canada in relation to the proposed guidelines. So the very subject matter before us, which is going to be how the decision came to be, and it had to do with whether pharmaceutical industry pressure did or did not play a role, involves the executive director, who is intimately involved in the discussions with the board members, and Madame Forcier herself refers to these in her resignation letter. So he, not only is he an appropriate witness, he's an essential witness.
Any further discussion on the amendment? Mr. Johari.
Sorry, just a short comment. Typically, we discuss about the emotion, and then we ask each side to submit their witnesses. Okay, and we don't sit here argue about who's going to submit what witness and why or not. Just simply consider the motion is put forward. We are in agreement as per the amendment, and now we are asked to go back and submit our witnesses by the end of the day, Friday. And now the list of witnesses in front of us. And everybody is agreeing, aside from one of the colleagues, whether that Mr. Clark is relevant or not. Well, our member from NDP says it's relevant, and he's going to submit it as a witness list. So it's going to be on the list of witnesses to be called. Simple as that. Thank you.
Any further discussion on the amendment? Are we ready for the question? All those in favor of the amendment to remove Mr. Clark as a witness, please raise your hand. One in favor, opposed. The amendment is defeated. Back to the main motion as amended by Mr. Van Couverden's amendment only. On the main motion, any further discussion? All those in favor of the motion as amended, it's passed unanimously. Thank you. That brings us to S203. And on remarkably short notice, we do have an expert here from the Legislative Council if there are any technical questions. So we're now, yes.
Mr. Chair, on Bill S203, there is no agreement between the leaders to discuss this. We had thought there was an agreement, but I learned earlier that there was no agreement. I think we need that consent to be able to discuss that today.
Mr. Thériault.
Mr. Thériault, what I have received is that I have the discretion as to updating the committee. And as you know, there were discussions, and the outcome of those discussions was to add this item. Unanimous consent is not required. So we are going to proceed now with this item. Mr. Chair, we took time at our last in-camera session to organize our work. And we got your advice that S203 would be on the agenda this morning at 10. Do you find that normal when you have, political training that to be able to file, amendments, and that just with such short notice, you say we're going to study a bill, and you're saying that you have learned that there had been agreement between the parties on this issue, which is in fact not the case. So it is not the outcome of the agreement. What I am challenging is that I have never seen this. I had 1 hour's notice that we're going to have a clause by clause at the agenda of a committee meeting. And what is at issue here is I'm not trying to obstruct. I know that for some this bill is extremely important. But I think that if we were to come back on Tuesday after the break and that we proceed then, we'll have had the necessary time for the bill to actually meet with his intentions that it be adopted in time for Autism Week. But I would not accept that we take the time we took to organize our work, and then at the last minute, you be contacted, by a body that's not official, and that you then put before us that we do a clause by clause with just 1 hour's prior notice. I submit that, that is not our usual practice. Mr. Theriault, you are entirely correct. I'm not at all comfortable with the situation we find ourselves in now. It is the result of discussions that it indicated there was an agreement. But here we are now.
Listen, it's important to me that we move this forward in collaboration with one another. I think we thought that there was an agreement. It's clear that there wasn't an agreement. And I think that it's probably more important that we wait and have some sense of collaboration and consensus on this than that we ram it through 5 minutes after the meeting end time. So I am good if we wait till our next meeting to deal with it.
Thank you so much, Mr. Lake. I think we're now ready for a motion for adjournment. Is that you moving the motion, Ms. Goodridge, or do you want to speak?
I'm going to move the motion that we adjourn the meeting.
Okay. All right. The clerk has asked me to see if I can get your agreement to adopt the budgets for the upcoming meetings. You did, and it's not debatable. All those in favor of adjourning the meeting? The meeting is adjourned. Sorry, clerk.